Okay, so now we're going to talk about some virus infections of the blood. And so viruses can be commonly found in blood, and this is a term called viremia. And so viruses are going to use blood cells to get around sometimes. Cytomegalovirus, for example, is a herpes virus, and this is going to be able to disseminate through blood. Arboviruses are a group of viruses that are transmitted by arthropods, and these are very important blood viruses: dengue virus, yellow fever virus, and then there's, of course, our ebola virus and our marburg virus that we'll talk about. So first is cytomegalovirus. This virus is a herpes virus, and so herpes viruses are notorious for being able to cause chronic or latent infections. Cytomegalovirus is going to be a persistent infection. You are going to get infected for life. And usually cytomegalovirus doesn't harm you. Typically, most people who have a healthy immune response will be able to keep this virus under control. But it's usually when you are immune compromised that this guy can pop up. So about 50% of adults over 40 are actually infected. Usually you're going to be infected through body fluids, and then your children, by about 5 months of age, usually 1 in 3 children have already been infected with CMV. Again, usually have no sign or symptoms. Immune compromise can lose control of the virus. This is a form of reactivation of the virus because it is latent, hanging out. And there can also be congenital infection in utero. This can cross the placenta. Now, cytomegalovirus is an infection that's going to be latent, but again, usually no symptoms. Your infants, if they do get infected during the pregnancy, they can actually have disseminated disease and neurologic damage. So it's important to make sure or test mothers for cytomegalovirus, especially if they're over 40 years of age. For cytomegalovirus, they are going to be able to infect the trophoblasts in the placenta, and this is how the virus spreads from the mother to the baby. Now, another group of patients that are highly susceptible are transplant patients because they are on immune suppressive drugs, so they can lose control of cytomegalovirus if they have the virus. Cytomegalovirus infections in these patients are going to target your epithelial cells, your liver hepatocytes, and also your immune cells, monocytes, for example, which will help to disseminate the virus further. Another side point is that if a patient is going to receive a transplant, an organ, and they are infected with the human cytomegalovirus, then this can lead to an accelerated rejection of the actual transplant. HIV, CMV is a opportunistic infection. One thing that happens in HIV-infected patients is that the epithelial cells in the retina can become infected, which can cause blindness. Now, another virus infection that's important for the blood is dengue fever. So dengue fever can lead to a hemorrhagic fever. There's about 4 millions of people infected every year. And there are 4 related viruses. So there's dengue type 1, 2, and 3, and 4, which are related. And currently there is no vaccine available for these viruses. You have some mosquitoes that are vectors, the Aegypti and the Ablopictus are going to be the mosquitoes that pass on dengue. So similar to malaria, prevention is going to be best to avoid mosquitoes. This is going to be the tropics and subtropics, and this is endemic. Central America, for example, has dengue fever. Now, for symptoms for dengue fever are going to be headache, pain behind the eyes, muscle pain, rash, and it's going to be itchy. Interestingly, it is in every part of the body except for the face. You're going to have, this is a hemorrhagic virus, so there will be some bleeding, easy bruising, hemorrhagic virus, and a low white blood count. Diagnosis is going to be in serology, in serum or autopsy specimens. And then when the fever declines, warning signs could develop at this point. So warning signs that someone is going to go into severe infection is abdominal pain. And this is going to coincide with vomiting that's persistent. You get red spots and patches on the skin, bleeding from the nose or gums, vomiting blood, tarry black stools, blood in the stool, pale, cold, clammy, irritability, difficulty breathing. And this is a virus infection, so there is no vaccine. This is going to be supportive care, mostly, that will help. You can give acetaminophen for treating fever, and then you're going to typically have to hospitalize the person. You want to avoid ibuprofen, aspirin, or other types that will cause blood thinning, because this is a hemorrhagic virus. Now, one other thing I want to point out about dengue virus is if you've had dengue type 1, for example, you will make a dengue type 1 response. So this is an anti-dengue 1 antibodies. And it's thought that when you get dengue type 2, in this person, we'll call this person 1. When you get dengue type 2, you get an exacerbated disease. And what the problem is that your dengue type 2 is not going to look like dengue type 1. And so those antibodies are not going to be able to help you with dengue type 2, except that it can recognize it just enough to allow for your dengue to now be picked up by macrophages, and then it can hitch a ride on macrophages to get throughout your body. And so it induces a severe disease. And it doesn't matter what order this is. Dengue type 2 first, dengue type 1 second will give you a severe disease. Dengue type 3 first, dengue type 2 second will give you a severe disease. So they tend to amplify each other. Now, another virus is a yellow fever virus. This is going to be more common in Africa and South America. This is going to be transmitted by mosquitoes. So it's going to be a very rare illness. And again, it has to do with the potential to get exposed to this virus if you want to think about whether or not a person has this. You're going to have a mild disease of fever, aches, and pains. If you do progress to severe disease, this is going to lead to bleeding with jaundice. Lab, test, symptoms, and travel history are all important in the diagnosis. There is no treatment. Of course, when you're traveling to other countries, you want to use insect repellents, and there is a vaccine available. So if you're traveling to a country that is endemic for yellow fever virus, you go to your practitioner, and they can give you the vaccine for that virus. Now, Ebola is a very famous hemorrhagic virus, but there is a sister or cousin to Ebola called Marburg. Both of these guys are filoviruses, and they're going to be hemorrhagic fever viruses. Now, Ebola and Marburg are going to cause hemorrhaging in the skin, mucous membrane, internal organs. You bleed out. You're going to have rapid hemorrhaging. The reason for this is still under investigation. It's thought that, for example, Marburg is going to replicate in the vascular endothelial cells. And so, of course, your immune system is going to kill infected cells. So if you kill your endothelial cells lining your blood vessels, that's going to cause leakiness. Ebola is going to cause symptoms in about 4 to 6 days after exposure. Mortality rate is very high, and there is currently no treatment except for passive antibodies. And there are some vaccines that are available. Ebola is very contagious, but again, very rare. Transmission is person to person or an infected animal. It's thought that bats are going to transmit it, but the primates might be a reservoir. Person to person is when people are going to encounter with infected blood, and they can transmit it to another person. 10% of the population in rural Central Africa carry Ebola antibodies, which means that they had the infection and survived the infection. And again, these people can be a source of antibodies to give passive therapy to people who are infected with it. Symptoms of Ebola virus disease are going to be fever, headache, muscle pain, weakness, vomiting, abdominal pain, and then, of course, bleeding and bruising. Diagnosis is going to be symptoms, potential for exposure. Oops, sorry, wrong one. Potential for exposure. Again, you went to an area that's endemic for Ebola. The exposure has to be blood or body fluids, objects contaminated with blood or body fluids. You're working in a clinic, in one of these endemic areas, and people were dying from Ebola in that clinic. Infected fruit bats and primates, or they can be passed in the sperm from somebody who has recovered from Ebola. Again, it's necessary to isolate. This is a BSL-4 pathogen. Supportive therapy is what's usually given. Now, Marburg is in the same group as Ebola, and this is also a hemorrhagic virus. This was identified in 1967. There were outbreaks in laboratories in Marburg and Frankfurt and Belgrade, and these were all exposed to African green monkey tissues. So each of these labs received African green monkey tissues from the same shipment, and it went to all 3 locations. And so you had 31 people overall infected with 7 deaths. Now, Marburg in the wild is going to get transmitted through fruit bats, and again, it's thought that primates are another host for this virus. The transmission can also be from human to human. Signs and symptoms are going to occur about 5 to 10 days after exposure, and you're going to get your typical flu-like symptoms. You're going to get a macropapular rash on the trunk of the body. You're also going to have nausea, vomiting, sore throat. When it gets serious, you're going to have jaundice, weight loss, massive hemorrhaging, similar to Ebola. And this can have a 25% mortality rate. Now, Marburg virus has signs and symptoms that are similar to malaria and typhoid, so it makes it difficult to diagnose. And again, it is a virus, so supportive care is important. You can also do an ELISA. You typically will do an IgM ELISA because most people have never been exposed to Marburg, so you would never look for IgG, for example, in a patient presenting with symptoms. It's most likely their first encounter. In deceased patients, you can look for virus isolation in tissues or in blood samples.